Okay, so let's start by open angle glaucomas. Starting first, so we'll discuss first the primary glaucomas, then the secondary glaucomas. We need first to have this concept of the spectrum of the diseases. So a glaucoma, first let me tell you what is the definition of a glaucoma. Is it a glaucoma is every patient with high intraocular pressure? No. Is it a patient who is with every patient with cupping or optic disc cupping? No. So who is a patient who can we call a glaucoma? He is a patient, if we are speaking about a primary open angle glaucoma, he is a patient with an open angle who has progressive visual field loss and progressive optic neuropathy in which there is high intraocular pressure, which is considered only a risk factor. So high intraocular pressure is not mandatory for a patient to call it glaucoma. As we will say, there is what's called the normal tension glaucoma. And also, the presence of high intraocular pressure is not enough to, if the diagnosis of glaucoma needs that the patient will have progressive visual field loss and optic disc damage. So that's why there is what's called ocular hypertension. So these circles will summarize it all. If a patient has an open angle with a progressive optic neuropathy, progressive visual field loss, high intraocular pressure, we call it a primary open angle glaucoma. If a patient has open angle, this yellow circle, the patient has open angle, progressive optic neuropathy with progressive visual field loss with normal intraocular pressure, so we call it normal tension glaucoma. The bluish circle, if a patient has open angle with high intraocular pressure, but normal intraocular pressure and normal visual field, then this is called ocular hypertension. Okay, so you now know the similarities in the spectrum between these three diseases. So let's start by the primary open angle glaucoma. So as we just mentioned that it is a disease, it's a chronic disease, so the patient will be unlikely that he will be the patient will be unlikely that recover from glaucoma. So it's a chronic disease. It is a progressive optic neuropathy that result in characteristic optic nerve head cupping and retinal nerve fiber layer thinning and functional visual field loss in which the high intraocular pressure is a risk factor. So these are the criteria that should be present in order to diagnose a patient with a primary open angle glaucoma. Dr. Muhammad Zakir, what is a suspect? A suspect who is any patient who doesn't fulfill the whole criteria for glaucoma, that you are still in doubt if this patient has high intraocular pressure or normal intraocular pressure, or his visual field is suspicious, his optic his OCT is suspicious, his appearance of his optic disc is suspicious. All those we can put them on a category of a glaucomatous suspect. That's why I'm telling you it is a disease of risk factors. There is no single criteria that will make you judge a patient is glaucomatous, but you are putting all diagnostic and the investigations glued together in order to remove this suspicion and confirm the diagnosis. If you cannot do this judgment, then this patient is still a glaucomatous suspect. Regarding the epidemiology, and please, these epidemiological data can be asked also in the MCQ exams, so concentrate. The primary open angle glaucoma is the commonest form of glaucoma, making around 60 to 70% of patients. 7% of normal population will have ocular hypertension. So not everyone with high intraocular pressure is glaucomatous. That's why we are saying that high intraocular pressure is a risk factor. 3% of population will have glaucomatous visual field effect. If damage in one eye, untreated, the fellow eye will have 29% risk of developing glaucomatous damage over the next 5 years. A steroid responder patients have 31% risk of developing glaucoma within 5 years. So those who show higher intraocular pressure rise within in response to steroids, they can develop glaucoma 31% risk higher. So what are the risk factors? Again, very important. First of all, increase the IOP. So if you find a patient with higher intraocular pressure, this will be the most important risk factor for patients to be diagnosed as a primary open-angle glaucoma, but it is not everything. Also decrease the central corneal thickness. Decreasing the central corneal thickness will be a risk factor. Increasing age, as we mentioned, Black race and Hispanics, family history, refractive error or myopia, the presence of larger fluctuations, more than 10 millimeter mercury between day and night, will be also suggestive of primary open-angle glaucoma. Patients who are diabetics or having hypertension or any other vascular diseases having retinal vein occlusion will also has higher risk of developing primary open-angle glaucoma, and patients who are on oral contraceptive pills. So these are the risk factors. When you find them, you are more prone to increasing it to be suspicious of glaucoma. You are more thinking that this patient will have rapid deterioration if his glaucoma is not controlled or if his intraocular pressure is not controlled. And this is also, the more the risk factors, the more you want the target pressure to be lower. And we'll speak about the target pressure in the next lecture. So that's why I'm always like stressing on the risk factors. So the risk factors, the more the risk factors, the more you have likelihood to diagnose a glaucoma. The next is the normal tension glaucoma. So we will defer the treatment until the next time. So we will just mention all the clinical diseases and the findings, because they will eventually they will all have the same treatment or the same same groups of treatment. Regarding the normal tension glaucoma, it is a chronic progressive optic neuropathy that results in characteristic optic nerve head cupping, retinal nerve fiber layer thinning, and functional visual field loss, but with normal intraocular pressure. So it has the spectrum of the primary open-angle glaucoma, but the normal intraocular pressure. That's why we are saying that the intraocular pressure is not a mandatory finding for glaucoma. It can be normal in normal tension glaucoma. So according to what is called the normal tension glaucoma study, it found that there are certain risk factors for patients to develop normal tension glaucoma. First of all, it is more in females. The most important risk factor is that it is associated with decreased central corneal thinning. So it is actually not, it is not well understood whether the central corneal thinning will cause the normal tension glaucoma, or the patients with normal tension glaucoma, it will have high, like, or it is not understood that whether this decreased central corneal thinning will cause the glaucoma, because those patients are underdiagnosed, as we just mentioned, and so that they will develop glaucoma unnoticed, or it is not known if it is that the glaucoma is what's causing the central corneal thinning, maybe because of the glaucoma with the effect of the aqueous and vitreous on the ocular coats. This will result in compression of the cornea, decreasing the central corneal thinning. So actually it is not well understood, but eventually it is correlated. It is a risk factor for the decreasing the corneal for normal tension glaucoma to have decreased central corneal thickness. Also, the increasing age, the more in old females, more in the Japanese race, and also family history have been linked. The myopia, as we just mentioned, in the glaucoma, systemic hypotension and vascular diseases. This is very important. It is not hypertension here; it is hypotension. And maybe this is because that there is one of the theories that that explain the normal tension glaucoma is that there is hypoperfusion of the optic disc. There is hypoperfusion. There is no enough blood supply is going to the optic nerve. That's why it is suffering. That's why this will result in death of the retinal nerve fiber layer. So systemic hypotension, vascular disease, Raynaud's phenomenon, all these vascular disorders have been linked to normal tension glaucoma. as well as the obstructive sleep apnea. So obstructive sleep apnea will also causing a momentary shutdown of the vascular blood supply because of decreasing breathing, and maybe during sleep. So this may also affect the blood supply and oxygenation that will result to the that will reach the optic nerve. So also have been linked to the theory of hypoperfusion to the optic nerve in normal tension glaucoma. Thyroid disease also, according to the study, also showed to be linked to the normal tension glaucoma. So how to suspect that one of the very important clinical signs is the presence of disc hemorrhage. So the presence of optic disc hemorrhage is very common in those patients with normal tension glaucoma, and it was also linked to optic disc compromise. This should be differentiated from other causes of optic neuropathies, such as neurological optic disc, and the treatment is directed toward increasing the perfusion of the optic nerve. So there are certain drugs which are called having a neuroprotective function on the retina and optic nerve. Maybe they are increasing the perfusion of the optic nerve, such as the alpha-2 agonists, which will cause neuroprotective effect on the retina and optic nerve. Some selective beta blockers, such as betaxolol, will have also neuroprotective effect on the retina and optic nerve. Carbonic anhydrase inhibitors, such as dorzolamide, may provide or may improve the ocular perfusion, and the prostaglandins will show greater ocular hypotensive effect. So they will not target the hypoperfusion, but they will just lower the intraocular pressure to massively in order to prevent the damage or the ongoing damage. The third disease in the spectrum is called the ocular hypertension. So I guess that you now know what is ocular hypertension. It is when the intraocular pressure is elevated, just that, nothing else. So no optic disc damage, no retinal nerve fiber layer damage, no visual field changes, nothing, just high intraocular pressure. So how many times did you encounter in your practice a patient with high intraocular pressure and you are wondering whether he is glaucomatous or not? Well, the ocular hypertension treatment study will answer your question. So there will be certain factors from developing a primary open-angle glaucoma from ocular hypertension according to the ocular hypertension treatment study. So when these factors are present, you are more likely to treat those patients. You are more likely to decrease the intraocular pressure because they have more risk to develop primary open-angle glaucoma. What are these risk factors? The increasing the age, the higher intraocular pressure at presentation. So most of the practice will agree on more than 30 millimeter mercury. So if the patient has more than 30 millimeter mercury, you are more likely to decrease this intraocular pressure. Thinner corneas also. If the patient has larger CD ratio at presentation, patients who are African American, so you see that the race is very important. Gender, it is more common in males. So you see here, this is the first time we say that there is a disease which is common in males or has more risk in males. Higher pattern standard deviation on perimetry. And according to this study, it found that myopia or diabetes or presence of family history of glaucoma does not increase the risk of developing primary open-angle glaucoma. So when they compared those patients to controls, it was found that those patients are not at specific risk of developing primary open-angle glaucoma. So for you who are interested more to know about the glaucoma studies, you will find a course in the application called the Clinical Trials and Studies in Ophthalmology. You will find that the glaucoma lecture is present for free, so you can watch it. So you can find all the glaucoma or the landmark trials and studies in glaucomas. Please refer to that, watch it because it is very important. And it will summarize all these studies and the trials. Okay, let me check your questions. Dr. Wala, even if not using steroids, well, we are saying that steroids will be an extra risk factor. So patients who are at using the steroids, if they show higher intraocular pressure increase, in response to these steroids, they will be at more risk of developing a primary open-angle glaucoma. Is normal IOP is different according to age? Yes, Dr. Islam. So it will tend to be more higher with higher age or older age. Where can we find the sheet? Which sheet? Which sheet are you speaking about, Dr. Atif? No, I'm not speaking about a sheet. I'm speaking about the trials lecture. There is a lecture. It's like a 1-hour lecture for trials and studies in glaucoma. Check the application, the iCourses app. You will find a course called Trials and Studies in Ophthalmology. The progression is judged by what is meant by the progression is judged by? Dr. Muhammad, are you asking about how can we judge the progression? You can judge the progression by as we mentioned, by the intraocular pressure as a risk factor, by the stereoscopic image of the optic disc, and by the investigations, like by progressive thinning in the retinal nerve fiber layer in the OCT, and also by progressive visual field loss in the perimetry. Okay, so far so good. You're welcome. Okay, so this is for the primary glaucoma. Let's now move to the secondary glaucomas. The most important and frequently asked and frequently encountered in practice is the secondary glaucoma, secondary open-angle glaucoma due to pseudoexfoliation syndrome. So what is meant by the pseudoexfoliation syndrome? It is a systematic syndrome which is characterized by deposition of abnormal material. It is a fibrillar-like material. It is a dandruff-like material all over the body. So it is deposited into the internal organs, but we don't see them. And it is also deposited into the eye. So this material or this abnormal basement membrane deposits are present on the iris margin. So they will give the iris margin what's called the moth-eaten appearance, this serrated and mammillated edge of the iris. Also, they are deposited into the anterior lens capsule, which will result in what's called the target sign. So the constriction and dilatation of the iris will sweep this material from the paracentral zone, leaving only a central zone and the peripheral zone. So it's called the target sign. So it appears like as if it is a pseudocapsule. It is present also in the corneal endothelium, leading to may result in corneal decompensation, present on the iris pigment epithelium or deposited into the back of the iris, also in the iris stroma, as well as other systemic organs like skin, heart, lung, liver, kidney, cerebral meninges. It will result in this moth-eaten appearance of the pupillary border. So those patients with pseudoexfoliation syndrome, you will find a specific finding in the gonioscopy. It is called the Sampolisi line. Sampolisi line is a heavily pigmented line or heavily pigmented trabecular meshwork. And there will be heavily pigmented trabecular meshwork, and also the Sampolisi line, which is a pigmented line anterior to the Schwalb's line. So this should be here. The pigmented line in front of the Schwalb's line, it is called the Sampolisi line. This is not diagnostic for the pseudoexfoliation syndrome, but it is highly suggestive for that because it can also occur in patients with pigment dispersion syndrome. So again, the Sampolisi line is a heavily pigmented line present anterior to the Schwalb's line, which occurs in the pigment dispersion syndrome and the pseudo exfoliation syndrome, but it's more common to in the pseudo exfoliation syndrome. So what is the problem for those patients as an ophthalmologist? Well, we have two main problems, the cataract and the glaucoma. Regarding the cataract, those patients will, this pseudo exfoliation material will be deposited into several tissues within the eye. So they will be deposited into at the edge of the pupil, resulting in poor pupillary dilatation. So those patients will have smaller pupil. Also, they will be deposited into the lens zonule. So this will result in zonular weakness, and this zonular weakness will make the lens tremulous or phacodenesis, make the iris tremulous or iridodenesis, and they will be giving more likelihood of complications intraoperative, like bag dislocation, like the lens dislocation, rupture of posterior capsule, dropping of the lens, and even it can start or it continues after the surgery. So even if the surgery went uneventful, then the patients may present later on by subluxation of the intraocular lens or dislocation of the intraocular lens, and so on. So this is for the cataract surgery, and for the this is the complications of the pseudo exfoliation in the cataract. About the glaucoma, so 50% of patients with pseudo exfoliation will develop glaucoma. So glaucoma is very important. Like if we are following up those patients who had cataract surgery after pseudo exfoliation, we follow up them for the stability of the bag and also for the development of glaucoma. And the glaucoma here is a secondary open angle glaucoma. So you remember we said that you can diagnose it after exclusion of the primary glaucoma. So we found that fibrillar-like material in the anterior lens capsule. So we diagnosed it as a secondary open angle glaucoma because we found a cause. So how much it is different from a primary open angle glaucoma? First of all, the race. The primary open angle glaucoma, it is more common in blacks, while the pseudo exfoliation glaucoma is more common in Scandinavians. Asymmetry, so it will be the pseudo exfoliation glaucoma can present monoocularly. However, this is not the case for primary open angle glaucoma. It will show greater trabecular meshwork pigmentation by gonioscopy, unlike the primary open angle glaucoma. It shows higher intraocular pressure. So those patients have more risk of worsening, like their glaucomas. They will show higher intraocular pressure at onset. They will show faster rate of progression. They will show worse prognosis, like they will show poor response to medical therapy. They will need more need for surgical intervention. So it will be worse in everything. They will also show complicated cataract surgery. So if this cataract surgery is complicated by vitreous loss, this vitreous loss can result in also adding to the glaucoma, with adding to the increased intraocular pressure. And it will be also associated with increasing inflammation post-surgery. Okay, so this is for the pseudo exfoliation. What about the pigment dispersion? Pigment dispersion is also another less common type of secondary open angle glaucoma, but it is very frequently asked in the exams. So in the pigment dispersion syndrome, or as I told you, back to the pseudo exfoliation, we always in most of secondary glaucomas, we are having a problem in the aqueous outflow. So remember when I told you that the aqueous outflow is the most important factor that will determine the intraocular pressure? In the pseudo exfoliation, there is a fibrillar-like material is deposited into the angle. So this is what are blocking the trabecular meshwork. And here in pigment dispersion syndrome, there is another thing or another material which is blocking the trabecular meshwork, which is pigment. As the name is implying, pigment dispersion syndrome. So there is a pigment which is dispersed all over the globe, resulting in blocking the trabecular meshwork. So what is the source of this pigment? The source of this pigment is from the iris. So as you know, and we just mentioned in the anatomy, that there will be a pigmented layer of the iris epithelium present on the back surface. Okay, so this is normal. And there should be a space, a potential space between the lens and the iris. Sometimes, especially in myopes, the iris is becoming concave. So when the iris is becoming concave, there will be rubbing of the back surface of the iris against the zonule. So you can think of it like there is a knife which is scratching the back surface of the iris. This will result in the dispersion of pigment from the back surface of the iris and deposit everywhere. They will be deposited into the back of the cornea, resulting in what's called the Krukenberg spindle. They will also, this will be like a spindle of pigment, usually vertical spindle, and it will be in this direction because of the convection current of the aqueous. And it is not necessary for diagnosis, so it is not mandatory for diagnosis. You can still diagnose a pigment dispersion without it, but it will be highly suggestive. Also, this pigment will be deposited into the lens and also in the angle, resulting in blocking the angle, resulting in glaucoma. So again, pigment dispersion. Not every patient with pigment dispersion syndrome will have glaucoma, but it will be a risk factor for developing a secondary open-angle glaucoma. So those patients will have very characteristic features. First of all, the iris mid-peripheral transillumination defects. You see, when we do transillumination to the pupil, you will find that the periphery of the iris is showing spike-like defects in the mid-periphery. What are these spike-like defects? These are just the location of the rubbing of iris against the lens zonule. So this is the anatomical distribution or anatomical orientation of the zonule. So when the iris is rubbing against the zonule, this will result in these defects. So the iris mid-peripheral transillumination defects are due to mechanical rubbing of the iris with the lens zonule. This mid-peripheral iris is often concave and with posterior bowing. So it will bow against the zonule. So that the laser peripheral iridotomy is not very beneficial. We don't use laser PI in such cases. And also the pigment deposition on the lens, it will result in what's called the Zentmeyer line. This is the Zentmeyer line, which is a pigment deposit on the lens equator seen after dilatation. When we do gonioscopy for those patients, we can also find the densely pigmented trabecular meshwork or the Sampolis line, or this line anterior to the trabecular meshwork and anterior to the Schwalb's line. And finally the glaucoma. So what will be the risk of glaucoma in those patients, and what will be the certain risk factors for those patients to develop glaucoma? The pigmentary glaucoma occur in 15% of patients with pigment dispersion syndrome. So 15% of patients with pigment dispersion syndrome will develop either glaucoma or ocular hypertension. And it has certain epidemiological predisposition, like it is more common in whitish and more common in myopic males. Whitish myopic males, 20 to 50 years old, very, very important in the exam, very commonly asked. Whitish myopic males, okay? It can also affect females, but if this is the condition, then they will be older than males. So it is more common in males, but if it affects females, they will be more old than males. This will be the same like a disease that we are going to discuss in the retina. It's called the CSR. CSR, or central serous choroidopathy. It's more common in males, more common also in young age groups. But if it's affecting females, they will become older. Also, it can show inheritance of autosomal dominant, and this is also asked before in the exams. Autosomal dominant inheritance in some families. And the clinical picture, those patients tend to be like sportmen. They will be like athletes. So they will be young, they will be myopes, because the myopia will have more incidence of bowing of the iris against the zonule. And they tend to be athletes because this activity will result in always constriction and dilatation of the iris. So more rubbing against the zonule. So this will result in those patients will have more incidence of pigment dispersion and more incidence of pigmentary glaucoma. So what will be the complaint? The classic presentation for those patients that they will report halos, intermittent visual blaring, and ocular pain. Why? Because of higher intraocular pressure. It will be the same like higher intraocular pressure in patients with angle glaucoma or angle closure glaucoma with totally different race and sex and age, but it will be the same clinical scenario. Patients will have halos, intermittent visual blaring, and ocular pain. This is because of high intraocular pressure. Like it can reach up sometimes up to 50 millimeter mercury. So those patients will have all of a sudden high intraocular pressure. They will report that there will be corneal edema causing these halos and intermittent visual blaring. This high intraocular pressure will cause ocular pain. So you will check the angle, you will find it is open, so it is not a closed angle. You check the cornea, you find the Krukenberg spindle. Check the angle, you find the you find the Sampolisi line. You can dilate the iris, you find the Zentemeyer line. So you and the patient will have myopia, so you diagnose it like a pigmentary glaucoma. So those patients will have IOP rise with pigment release in the AC with exercise or pupillary dilatation. And the prognosis for this case is good. It is eventually good. Why? Because eventually all the pigments at the back of the iris will vanish. Eventually, at some time or at any point, the whole pigments will be disappearing or will end. So they eventually they will have more good prognosis, and also they have certain consideration in the treatment. It was found that laser trabeculoplasty is very effective in such conditions. So it was helpful in clearing the pigment in the trabecular meshwork. So laser here, very, very effective, very commonly used, and it should be considered in such cases. Okay, Dr. Yahya, severe pain? No, Dr. Yahya. Usually it is not severe pain. It can reach 50 millimeter mercury, but for most of cases doesn't reach that high. Okay, so these are the pseudoexfoliation glaucoma, pigment dispersion glaucoma are very common questions in the exams. Let's now talk about the lens-induced glaucoma. So we talked about them rapidly in the lens. So let's now discuss them in more details. First of all, what is the phacolytic glaucoma? As we agree that in trabecular meshwork will be closed by something. It will be blocked by something. And in pseudoexfoliation, it is blocked by the dandruff-like material. In pigment dispersion syndrome, it is blocked by pigment. In phacolytic glaucoma, it is blocked by leakage of lens proteins. So those patients who have hypermature or mature cataract, like that, they will have wrinkled capsule, and they will have more incidence of diffusion of lens protein from inside the lens to outside the lens. So what happens when there is diffusion of lens protein? The macrophages will recognize it because the lens proteins are antigenic. So they will engulf these lens proteins. And then the macrophages will be swollen with the lens proteins, and they will be deposited into the trabecular meshwork, causing the blocking of the trabecular meshwork. So the scenario is a patient who is mature or hypermature cataract, and then this patient is presenting with severe pain of his eye, and you find the patient, when you examine the patient, you find the mature or the hypermature cataract, you find the presence of pseudohypopyon, which is simply the lens proteins with very high intraocular pressure with intact capsule. This is very, very important. Those patients have intact capsule. For the MCQ, there is no disruption of the lens capsule. There is the diffusion occurs through the intact lens capsule. So those patients, this lens protein will induce inflammation, so it will cause uveitis, resulting in prominent cells and flare, but no KPs for such cases. Pseudohypopyon is common, and the treatment is for all for all lens-induced glaucoma. It will be intraocular pressure control, inflammation control, and cataract extraction. So again, for the scenario, when you when the question asks you what is your next step, what is your immediate management, it is not cataract surgery. You need first to do two things: control the inflammation, control the IOP. Again, control the inflammation, control the IOP. For the third time, control inflammation, control IOP, giving anti-glaucomatous and steroids. This will control the inflammation and control the pain, control the intraocular pressure. Okay. The second one, a lens particle glaucoma. So again, we have a glaucoma caused, an open angle glaucoma caused by a lens. And in this case, there is disruption of lens capsule. Like if you did cataract surgery, or you did capsulotomy, or you did or there is trauma, anything that opened the lens capsule, resulting in liberated lens cortex. So this lens cortex will obstruct the trabecular meshwork. It can occur within weeks or months or years after event. So this reminds me once, what happens once in my lifetime, of a patient who was, I was doing him cataract surgery, and the patient was annoyed. So he may be having like, I realized later that he has a claustrophobia. So he was like he has a fear from closed from closed areas, or when you put the drape, he was not comfortable, but he was like he was irritated all the surgery. I was trying to finish the surgery quick, but he in the when like I finished the two quadrants, then then the patient, all of the sudden, he get up from the surgical bed. Literally, the patient get up from the surgical bed with his phaco probe inside his eyes. Can you imagine that? So it is not like he is moving his hand. He literally, his head was like 1 meter away from as I was doing him the surgery. So I remember that because this when I try to calm the patient down, call the anesthesiologist to give him like a sedative, and I found like there is a huge area of cortex is in the anterior chamber. So, or the nucleus itself, it will be like a large part of the nucleus, and the patient was refusing to to complete the surgery. You know, the patient was he was telling me, no, that's enough. I don't want to complete the surgery. This is enough for me. So I will walk away, go home with this remnant part of the lens. So should I do him? Like, should I leave him? We shouldn't. Why? Because if this remnant in nucleus is antigenic, it will obstruct the angle. It will cause glaucoma. It will cause uveitis, inflammation. Okay. Dr. Knana, but in case no response to medical treatment. No, Dr. Knana, you didn't get me right. We don't give the medical treatment as a final treatment. It is an immediate management or a temporary measurement until the inflammation subsides and the intraocular pressure decrease. Then we go for surgery. The surgery is the definitive management for all cases of lens-induced glaucoma. Okay. Well, eventually it will subside. If not, then give the patient mannitol. Mannitol will causing the decrease of the intraocular pressure. So even in patients with glaucoma, the patients who are already glaucomatous, we give them mannitol preoperatively, and the intraocular pressure will subside. So if the medications are not enough, just give mannitol. No, Dr. Yahya, no need for PI. PI, we do it for angle closure. There is no angle closure. There is totally different mechanism. Okay, so For patients, and by the way, the PI will increase the inflammation. So you are worsening the patient condition if you are doing him a PI. Okay, so back to our case, our lens particle glaucoma. So those patients will have free cortical material in the AC. They will have high intraocular pressure, moderate AC reaction with corneal edema. And if it was left like that, this inflammation will eventually cause posterior synechia and peripheral anterior synechia. So what is the treatment? You know now. Medication to decrease the intraocular pressure, mydriatics and cycloplegics to inhibit the synechia formation, topical steroids to decrease the inflammation, and surgical removal of the lens material. This will be the definitive management. A third type of lens-induced glaucoma called phacoantigenic glaucoma. This has another name in the past. It was called the phacoanaphylactic glaucoma, but this is a misnomer. It is not a correct name because there is no anaphylaxis here, or the anaphylaxis or type 1 hypersensitivity reaction. It is not the case in the phacoantigenic glaucoma. Okay, so for those patients who had lens surgery, like those patients will have open lens capsule. So the open lens capsule will result in exposure of the lens protein after the surgery or after penetrating trauma. So what is the problem? Or what is the difference between this and the previous case, or the lens particle glaucoma? Here, the glaucoma is not caused by the lens material clogging or blocking the trabecular meshwork. It will be caused by a reaction between these exposed lens protein and the immune system, which will recognize these lens proteins, and this will result in a granulomatous inflammations. A granulomatous inflammation, this is very important, asked also in the exams. Granulomatous inflammation occur in the phacoantigenic glaucoma because of the reaction toward the exposed lens protein. This will result in moderate anterior chamber reaction. There will be KPs or keratic precipitates on the corneal endothelium and anterior lens surface. Also, sometimes low-grade vitritis, synechia, and residual lens material in the anterior chamber. So this granulomatous inflammation is what's causing the glaucoma. So the treatment will be the same, medically with steroids and equosuppressants, surgical removal of the lens material, and fortunately, the glaucoma is not common here. Dr. Yahya, for the phacolytic glaucoma, no PI? Again, no PI. Why you do PI? So PI, again, will increase the inflammation. It will not target the pathology. So it will result in more, the patient has exposed lens proteins that will cause inflammation. So the PI, I'm going to tell you now what is the role of PI in case of angle closure glaucoma. So just wait for that, it will be explained. So as a general rule, we do PI for closed angle glaucoma, okay, not for the open angle glaucoma. Okay, for the intraocular tumors, how can intraocular tumor result in glaucoma? It will result in glaucoma by two main mechanisms. Either an open angle glaucoma, like trabecular block, and you would say, how do we say, you told us that in open angle glaucoma, it can be blocking of the trabecular meshwork by pseudoexfoliation material or by pigments or by lens material. How it is called an open angle with the trabecular meshwork is blocked? So we call an open angle glaucoma when the trabecular meshwork is blocked by anything except the iris. If it is blocked by the iris or it is closed by the iris, we call it an angle closure glaucoma. Okay, so whatever the material that is closing the trabecular meshwork, it is an open angle. If it is the iris, it is a closed angle. So for the trabecular meshwork, in case of intraocular tumors, they can be by direct tumor invasion. And this is the commonest cause of glaucoma in primary or metastatic tumors of the ciliary body or solid iris melanoma. Remember when I showed you the picture of iris melanoma in the pathology lecture? And I told you it can be associated with ectropion UV or localized cataract or glaucoma. So how does it cause glaucoma? By direct angle invasion of the tumor. Or it can be due to deposition of tumor cells. So there could be deposition of cells within the angle, like tumor cells in iris melanoma or tumor seeds from retinoblastoma, but it is not the commonest commonest form of angle glaucoma. So this is very important. They will ask you what is the commonest cause of glaucoma in retinoblastoma. I'm going to tell you right now. It can be by tumor seeds, but not the commonest. Inflammatory cells and cellular debris within the trabecular meshwork, macrophages that ingested the pigment of iris melanoma, that's what's called the melanocytic glaucoma. In melanocytic glaucoma, there will be macrophages ingested the pigment of iris melanoma and deposited into the trabecular meshwork. Or it can be due to intraocular hemorrhage, as I'm going to show you right now. Secondary angle glaucoma can be either by angle rotation, so by ciliary body rotation, or anterior displacement of the iris lens diaphragm, as in choroidal melanoma. So choroidal melanoma will push the iris lens diaphragm, leading to that the angle will be closed by the iris. Or it can be by neovascularization of the angle. So this is the commonest mechanism for choroidal melanoma and retinoblastoma. So a common question in the exam, what is the commonest cause of glaucoma in the retinoblastoma? It will be the angle neovascularization, causing an angle closure glaucoma. Okay. Okay. Regarding the inflammatory glaucoma, so this is another entity of glaucomas, and this is very interesting entity because it is inflammatory glaucomas. This is a glaucoma which is characterized by high intraocular pressure. However, it is treated by steroid. So you may be wondering how could it be that a glaucoma and it is treated by steroid? This is because the steroid is controlling the actual process that will result in glaucoma. So those patients will have inflammation, and a source of inflammation or uveitis, which will be causing edema of trabecular meshwork, endothelial cell dysfunction, blockage of trabecular meshwork by fibrin and inflammatory cells, prostaglandins mediated a breakdown of blood aqueous barrier, so bringing more inflammatory mediators and making the aqueous more thick because of plasma proteins, resulting in more blockage of trabecular meshwork, Schlemm's canal blockage, and steroid induced. So what are the common uveitis diseases characterized by open angle glaucoma? So the viral uveitis is characterized by high intraocular pressure. So herpes simplex iridocyclitis, herpes zoster iridocyclitis, juvenile idiopathic arthritis, and the Fuchs heterochromic iridocyclitis. All these diseases are characterized by high intraocular pressure. So let's start by a common disease in exams, but not very common in practice. It is called the glomeatocyclitic crisis or the Posner-Schlossman syndrome. So it was thought that it is one of the inflammatory glaucoma. It occurs more common in middle-aged men, or more in middle-aged patients. It's commonly to be unilateral, and those patients will have recurrent attacks of high intraocular pressure that may result eventually in chronic secondary open angle glaucoma. So this scenario is very common in the exam. A patient who is coming to you with a white eye, this is very important, white eye, there is no pain, and he was like coming for another reason. And when you examine him, you find that the intraocular pressure is very high, like 40 to 50 millimeter mercury. However, the patient is asymptomatic or having like very minimal pain. And he's having a white eye, And when you examine him, you find that the high intraocular pressure with very low grade inflammation, like small, white, round, discrete keratic precipitates on endothelium and trabecular meshwork. So the diagnosis for this case, it will be the glomerulocyclitic crisis or the Posner-Schlossman syndrome. So it is not angle closure, because if it's an angle closure, the eye will be severely injected with not white eye, and the patient will be in severe pain. And in angle closure, there will be no discrete KPs or no uveitis. So it was thought that it has an unknown etiology, but it was thought that it could be due to herpes simplex virus trabeculitis. There is inflammation of the trabecular meshwork by the herpes simplex virus, which will result in this glomerulocyclitic crisis. It is unknown, Dr. Islam, unknown. Okay, and it could be an autoimmune disease. Another disease is called the Fuchs-heterochromic iridocyclitis. In Fuchs-heterochromic iridocyclitis, it occurs in middle-aged men and women. Also, this is one of the inflammatory glaucoma. Those patients will have iris heterochromy. So they will have different iris color between both eyes. Usually the affected eye is lighter. However, this is not always, because this also asked before in the exams. It is usually the lighter, because this occurs in the patients who have dark iris. In those who have dark iris, the inflammation will result in that the affected iris will be lighter. However, if a patient has light colored iris from the start, the inflammation and the thinning of the iris tissue will lead to exposure of the blackish iris pigment epithelium. So the affected iris will be darker. Those patients will have low-grade anterior uveitis with a small stellate keratic precipitates. There is no hyperemia. Like those patients also will have more quiet eye. It is very common for those patients to have post-cataract, and the most common cataract is the posterior subcapsular. It's asked before. They could develop chronic open angle glaucoma in 15% of cases. There is also very famous sign that those patients will have fine vessels in the angle. These fine vessels will bleed on opening of the anterior chamber. Like on those patients who are doing cataract surgery, we are opening paracentesis. So this paracentesis will injure these fine blood vessels in the angle, leading to intraoperative hyphema. So this is called the Amsler sign. And the secondary open angle glaucoma doesn't correlate to the inflammation. So if it develops, it will be more severe despite the minimal inflammation. Another cause for higher intraocular pressure or secondary open angle glaucoma, it will be the raised episcleral venous pressure. So if a patient has raised episcleral venous pressure because of, as we mentioned before, like the patient with port Weinstein or the choroidal hemangioma, or the presence of carotid cavernous fistula, or the presence of orbital tumors, any compression of the globe from behind by an orbital tumor. This will result in increasing the episcleral venous pressure, resulting in stagnation of the blood vessels, stagnation of the blood within the blood vessels, like dilated tortuous episcleral veins like that. High intraocular pressure with blood in Schlemm's canal. Remember, blood in Schlemm's canal, like the Sturge-Weber syndrome. So the diagnosis will be by MRI, and to check what is, if any tumor, like if this patient has proptosis, or MRA to check for what is causing any abnormalities in the arteries, or any, like, if there is carotid cavernous fistula. And this patient is unlikely for the medication to lower the intraocular pressure below the episcleral venous pressure. So this kind of glaucoma will not be very responsive to the medical treatment. We need to address the cause. Aqueous suppressants are more effective than the outflow agents. So for those patients, if you are just trying to open the trabecular meshwork by any drugs, this will result in that the trabecular meshwork have already higher resistance. So the method of treatment is to just suppress the aqueous outflow, like by giving the patient beta blockers, or an alpha 2 agonist, or to do cyclodiode photocoagulation, you need to decrease the amount of aqueous that is secreted. This will be better to control this case. Laser trabeculoplasty is not effective, and the glaucoma surgery has higher risk. So those patients will have more risk of seriochoroidal effusion or suprachoroidal hemorrhage. Again, because of the higher episcleral venous pressure. Let's now move to the another topic, which is the traumatic glaucomas. So traumatic glaucomas can be, this is the normal outflow of the eye. So you can see that the aqueous is secreted by the ciliary process through the small pupil or through the pupil to from posterior chamber to the anterior chamber to be secreted by the aqueous to through the trabecular meshwork. However, there are what is called angle recession glaucoma. In angle recession glaucoma, that there will be trauma to the eye. This trauma will lead to rupture of ciliary body and the part between the iris root and scleral sphere. So the angle will be receding. The angle will be receding, leading to resistance to the aqueous outflow. This will be one case of traumatic glaucoma. Others will be iridodialysis, iris sphincter tear. These are all cases of glaucoma or cases of trauma that can result into the eye. One of them will be the angle recession. And another effect of the trauma, it will be like a presence of cyclodialysis cleft. So there will be a space between the choroid and the ciliary body. So this will result in that more diffusion of the aqueous, more absorption of the aqueous, or more drainage of the aqueous, leading to hypotony. So let's start first by the angle recession glaucoma. Angle recession glaucoma, it is a chronic unilateral secondary open angle glaucoma. Usually it is underdiagnosed because you need to ask about the history, and the patient needs to remember all the trauma which may occur months to years from the trauma. So it occurs in less than 10% of population after 10 years from the trauma. The main pathology that there will be tear between the longitudinal and the circular fibers of the ciliary body. And the glaucoma occurs mainly due to trabecular meshwork damage rather than the angular recession. There will be increased amount of angular recession, or the more the angular recession, the more the risk of glaucoma. And it was like very strange about this disease that you found that 50% of the fellow eyes may develop high interocular pressure. This is something like sympathetic ophthalmia, where the other eye sympathizing with the traumatized eye. It is not understood why this happened, why those patients who have normal eye, they develop glaucoma after the other eye has been traumatized. So it was suggested that the angle recession glaucomatous eyes may be predisposed to developing glaucoma from the start. The treatment for those patients will be aqueous suppressants. So I'm just stressing on the diseases where there is specific treatment for or specific precautions in the treatment. For the angle recession glaucoma, the aqueous suppressants and alpha-2 agonists will be helpful. Argon laser will be of limited efficacy and low success rate. And the treatment, if the medical treatment is not effective, so the treatment will be trabeculectomy with antimetabolites. And if it is not effective, so it will be the artificial filtering device or glaucoma device. So what will be the characteristic features of angle recession glaucoma in gonioscopy to differentiate it from open angle glaucoma? First of all, to differentiate it, just look for the other eye. So there will be difference. For open angle glaucoma, the angle will be open for both eyes, while in angular recession glaucoma, there will be difference. Here in the angular recession glaucoma will be the most prominent feature is the widening of the ciliary body band. So you see here is the angle. You see this dispersed pigments, which indicates the presence of previous trauma. Maybe these are coming from the iris or ciliary body. And you can see this is normal angle, and once all of a sudden there is broadening of the ciliary body band. So this broad ciliary body band occurs due to the tear between the longitudinal and the circular fiber. So the ciliary body becoming more wide and more visible. Okay. So this will be a feature. Or other features, it can be absent or torn iris process. So when you check 360 degrees, white glistening of the scleral sphere, depression in the overlying trabecular meshwork, and there could be localized peripheral anterosynechia at the broader end of the recession. Another condition that can result from trauma and affect the intraocular pressure will be the cyclodialysis cleft. In the cyclodialysis cleft, there is a separation from the of the ciliary body from its attachment to the scleral sphere. So back to the anatomy, the ciliary body is attached to the scleral sphere through its longitudinal fibers. So those patients, when they are subjected to trauma, this can result in avulsion of the ciliary process or the ciliary body, resulting in hypotony. Why? Because the aqueous is now passing through this defect between the scleral sphere and ciliary body into this potential space between the suprachoroidal space. So there will be like a new access or a new drainage location for the aqueous humor. So this will result in hypotony. So it will be the same mechanism of uveoscleral pathway. So we said that the uveoscleral pathway, the aqueous will be absorbed through the iris root to the ciliary body to the suprachoroidal space. Here we are like enhancing the uveoscleral pathway by creating artificial pathway for the aqueous. So the increased uveoscleral outflow throughout the cleft into the suprachoroidal space with possible decreased aqueous production from the vascular promise to the ciliary process. So these are the mechanisms why those patients will have hypotony. Later on, this cyclodialysis cleft may close, leading to glaucoma with higher intraocular pressure. So this may be due to abnormal function of the trabecular meshwork. And this usually can be a temporary thing, or after closure of the cyclodialysis cleft, it could be temporary rise of the temporary rise of intraocular pressure with glaucoma. So we need only temporary intraocular pressure control, and for the other occasions it may persist. Another condition which happens also due to trauma is hyphema. So hyphema is also one of the traumatic glaucoma that may result. They occurs due to blood in the anterior chamber. So this blood will result in obstruction of the trabecular meshwork by the RBCs or inflammation or debris directly into the anterior into the trabecular meshwork. So what will be the risk of developing glaucoma? We will summarize it like a large hyphema. There will be increasing the risk of glaucoma, like 50% of total hyphema, but we will just break it down because it was asked before in the ICU exams. Recurrent hemorrhage, or the hemorrhage between 3rd to the 7th day, this will increase the risk of glaucoma. So there will be like lysis of the clot. If there is a presence of a clot, we need to check the patient after between 3rd to 7th day, because the lysis of this clot will result in increasing the risk of glaucoma. In case of the sickle cell, in sickle cell disease, there will be at higher risk of developing a glaucoma. Why? Because the RBCs are sickle in shape. So they will be tend to more ability of the RBCs to block the trabecular meshwork because of this abnormal shape. Okay, so the RBCs will sickle in the aqueous humor due to acidity of the stagnant aqueous and have difficulty passing into the trabecular meshwork. So you see, the acidity is very important. That will result in blocking of the trabecular meshwork, and there will be increasing incidence of glaucoma following hyphema, as I mentioned. Small hyphema may result in increased intraocular pressure, and the decreased microvascular perfusion of the optic nerve head will make the optic nerve most sensitive to the elevated intraocular pressure. So these are the mechanisms why those patients will have high intraocular pressure after the glaucoma. It could be the sickling of the RBCs, it could be microvascular perfusion, or like blocking of the of the optic nerve head blood vessels by the sickled RBCs, and those also will have lower threshold for surgery. So this will be the why those patients with sickle cell disease having risk of glaucoma. Regarding the grading of glaucoma, so it can be classified into 5 grades, or a grading of hyphema, sorry. 5 grades. So the grade 0, that there is no visible layering of the blood, but there is only RBCs within the anterior chamber, what we called the microhyphema. So you can't see a level of blood in the anterior chamber, but just circulating RBCs in the anterior chamber. Grade 1, where the blood is less than 1/3 of the anterior chamber. Grade 2, when it is between 1/3 to half. Grade 3, when it will be between half, but it is less than total, so it is subtotal. And the grade 4, it is complete filling of the anterior chamber with blood. So it is called then total hyphema. And if the blood is turned into dark red blood, then we call it a black ball or 8-ball hyphema. And this black ball is suggesting the impaired aqueous circulation. Okay, so here are the grades. Microhyphema, grade 1 less than 33%, grade 2 between 33 to 50%, grade 2, grade 3 more than 50%, grade 4 more than 100%. So grade 1, regarding the risk of glaucoma, for the grade 1, which has less than or 1/3 of level of hyphema, and grade 2 between 1/3 and 1/2, grade 3, which is subtotal, and grade 4, which has total. What will be the risk of glaucoma in each one of them? This was asked before in the advanced ICO test. So the grade 1 will be 13.5%. So this will, or the grade 1 and the grade 2, it will be 13.5%, and the grade 3 will be 27%. Grade 4 will be, as I told you, 50%. Around 50% of those patients will develop glaucoma. And for patients with sickle cell, it is a total different story. The rebleeding cases, it will be higher than 50%. So those patients are more risk of developing glaucoma. So what will be the treatment for patients with hyphema? It can be conservative in the start, especially if mild hyphema, small hyphema, low intraocular pressure, but we need to avoid certain medications. We need to avoid myotics in all patients, because myotics will break the blood aqueous barrier, causing more inflammatory mediators to enter into the anterior chamber, increasing the inflammation. Topical carbonic anhydrase inhibitors, because they will increase the sickling. So they will increase the acidity to increase the sickling in the sickle cell disease. So they will be contraindicated in sickle cell disease. We avoid also alpha-1 agonist in sickle cell disease, because it will result in vasoconstriction. Systemic carbonic anhydrase inhibitors and hyperosmotic agents may cause sickle cell disease, or will cause sickle cell crisis in dehydrated individuals. So again, systemic carbonic anhydrase will cause acidity, increasing metabolic acidity. So hyperosmotic again will do that. So making the increasing the acidity by the systemic carbonic anhydrase, or increasing dehydration of the body by the hyperosmotic agents like mannitol, this will result in more incidence of sickle cell crisis, more incidence of optic nerve insult, more incidence of clogging of the trabecular meshwork. So these drugs, they should be avoided in such conditions. So we need to manage the patient medically until there are indications for surgical evacuation or anterior chamber wash. So what are these indications? If the intraocular pressure is more than 35 to 50 millimeter mercury in 3 to 5 days, so the intraocular pressure failed to lower, or if there is intraocular pressure more than 25, so the threshold will be lower in less than 24 hours in sickle cell disease. So in sickle cell disease, all our parameters and all our calculations and intervention should be at more invasive. So we need to interfere more rapidly. If the patient has any risk of corneal blood staining, like if the patient has higher, more of total hyphema, or if it has higher intraocular pressure, so there is more risk of corneal blood staining, and there is risk of synechiae. Another kind of traumatic hyphema or traumatic glaucoma is called the hemolytic glaucoma. In the hemolytic glaucoma, it is occurring after vitreous hemorrhage. So if a patient has trauma and this trauma results in vitreous hemorrhage, if there is no barrier between the anterior chamber or posterior chamber, like if the patient is aphakic, like the patient has disturbed anterior hyaloid, then the RBCs will travel easily from the posterior chamber to the anterior chamber. And this RBCs will be engulfed, and the hemoglobin in this RBCs will be engulfed by the macrophages. So the macrophages will be engulfing this hemoglobin, and then these macrophages will be present in the anterior chamber as red tinged cells. They can show reddish brown discoloration of trabecular meshwork and block the trabecular meshwork, causing transient secondary open angle glaucoma. Okay, so this shouldn't be confused with this one, which is the ghost cell glaucoma. So in hemolytic glaucoma, there is hemoglobin-laden macrophages. This is very important in the exams. What will be the structure that is closing the trabecular meshwork? In the hemolytic glaucoma, it will be macrophages that engulfed hemoglobin. So the hemoglobin just released from the RBCs in hemolytic glaucoma, engulfed by the macrophages, and now deposited into the trabecular meshwork after vitreous hemorrhage. Also, after vitreous hemorrhage, there is another case of glaucoma called the ghost cell glaucoma. In the ghost cell glaucoma, it is the degenerated RBCs, which are called the ghost cells, is the one which is blocking the trabecular meshwork. So the vitreous hemorrhage occurs, and maybe after 2 to 3 months, there will be the RBCs will degenerate, and then these RBCs, how do they degenerate? They will lose their intracellular hemoglobin. And if you want to check for them, do anterior chamber tap, you will find what's called Heinz bodies, asked before in the MSQs. These Heinz bodies appears as khaki in color. This you know this khaki color, which is the color of the uniform of army. You will find in the anterior chamber small khaki colored cells. These cells, which are degenerated or ghost cells, are less pliable, so they tend to block the trabecular meshwork more easily, causing secondary open angle glaucoma, which occurs after 1 to 3 months after vitreous hemorrhage through the disturbed hyaloid. Those patients will have non-inflamed eye, with the gonioscopy showing layers of the cells inferiorly. If the intraocular pressure is high and not getting better, then anterior chamber wash out with or without parsoplantar vitrectomy. Red cell glaucoma is the hemolytic glaucoma. So it will be like red discoloration of the trabecular meshwork because of the macrophages with hemoglobin. Okay. Another case of open angle glaucoma, it will be the UGH syndrome. UGH syndrome or OCH syndrome, it is referring to uveitis glaucoma hyphema syndrome. It is a syndrome of an open angle glaucoma which occurs secondary to presence of an IOL. So this IOL will cause what's called chafing of the iris. Chronic chafing of the iris, like rubbing of this IOL against the iris, result in loss of the iris tissue, resulting in persistent inflammation. This can happen in anterior chamber IOL or sulcus present or sulcus fixed IOL, or posterior chamber IOL if it is causing, if there is like haptic, their haptic will be out of the bag, eroding the surface of the iris. So those patients will have signs of chronic inflammation. They will have iris like cells in the anterior chamber. They will have cystoid macular edema, iris new vessels, the iris new recurrent hyphema, or there will be the recurrent hyphema because of bleeding or rubbing of this haptic or this IOL against the iris blood vessels. So also there will result in transillumination defects. And in order to diagnose, we will find it if you like, you just find you don't know where is the source of this inflammation, and the patient doesn't have any visible iris defect. Just to do a UBM, it will show you the contact between the haptic or the optic to the back surface of the iris. And the treatment for such cases will be the lens exchange. Another case of an open angle glaucoma, secondary open angle glaucoma, it's called the Schwartz syndrome. In Schwartz syndrome, there will be glaucoma associated with rheumatogenic retinal detachment. So when the patient has retinal detachment like that, if there is a break like here, the break will allow liberation of the photoreceptors from this break from RPE, and they will travel from the posterior chamber to the anterior chamber until they block the trabecular meshwork. So again, this is a very common question in the exam. In the Schwartz syndrome, what is blocking the trabecular meshwork? It will be the photoreceptor outer segment. So this is the reason why those patients have high intraocular pressure, and usually the intraocular pressure will normalize after the retinal detachment repair. Another case of glaucoma, which is occurring after PKP or penetrating keratoplasty. So we mentioned before that penetrating keratoplasty will be the higher at risk of complications after among all keratoplastic procedures. Why? Because we open the eye. So it will be associated with higher risk of glaucoma, and this glaucoma could be either open angle or closed angle. Why it happens due to open angle? Maybe due to inflammation. So there could be a persistent inflammation post-operatively, resulting in inflammatory glaucoma. Or high intraocular pressure can be due to post-operative due to viscoelastics, retained viscoelastics. Or it can be due to steroids. So this is very common. Those patients will be on long-term steroids for like a year or so, and they will have more liability to develop angle or glaucoma. So it is not uncommon that those patients are on long-term steroids, and when we remove the sutures and we find that the patient cannot see well, maybe because he had optic atrophy from the steroids that he was receiving all the year. It's also due to wound distortion. So if the wound edges are not coapted well, this especially if there is traction, like if there is a small graft with traction suture over the angle, this will result in wound distortion and angle distortion. Fibrous and epithelial downgrowth, which also can happen after penetrating keratoplasty. So there is like introduction of epithelial sheet below the endothelium, which will creep over the angle, resulting in secondary open angle glaucoma. We will also discuss this later. Or the glaucoma can be closed angle, which can be due to peripheral anterior synechiae. That's why in patients who are liable to develop peripheral anterior synechiae, we should do synecholysis intraoperatively. Pupillary block. So pupillary block we will say that in closed angle glaucoma, or it can be due to also epithelial, it could be due to ingrowth. Finally, the effect of drugs on open angle glaucoma. You see that there are certain drugs that can result in changing or increasing the intraocular pressure. First of all, the cycloplegics. Cycloplegics can increase the intraocular pressure by crowding of the angle, but usually if a patient has an open angle, this effect will be transient. Steroids, that third of patients will respond, but not all clinically significant. Like it was found that only 30% of patients will show increase of the intraocular pressure in response to steroids, but not all of them, of course, will develop secondary glaucoma. So why the intraocular pressure is increasing? This is because of increased resistance at trabecular meshwork. And this is very important and asked before. What are, again, the risk factors? What makes a patient at particular risk of higher intraocular pressure increase with steroids? If the patient is already glucomatous, or he has a sibling with glaucoma, or he is young, or he has diabetes type 1, or he is myope. Those risk factors should to be more associated with increasing the intraocular pressure after steroids. 4 to 6% respond with increasing by 15 millimeter mercury, and the rest will like 85% will only increase by 6 to 15 millimeter mercury, and it occurs with all routes of administration, like systemic, like oral, like topical, like intravitreal, periocular, subtenon, inhalation. All kinds of steroids will increase the intraocular pressure, but the more the intravitreal will be associated with more risk, and the longer the duration, and with the specific kinds of steroids, it will be more risk, like, or most likely with these drugs: prednisolone, dexamethasone, and intravitreal. Okay, so intravitreal injection will show increase in the intraocular pressure up to 50% of patients, and 25% of this will need medical treatment, and around 1 to 2% will need filtration surgery. Okay,